Alright, welcome to this class. In this video, we'll talk about SERM. SERM stands for Selective Estrogen Receptor Modulators, and these are drugs that act as agonists on certain estrogen receptors and as antagonists on certain estrogen receptors. So they have the ability to act as agonists on certain estrogen receptor and also act as antagonists on certain estrogen receptors depending on what we want. You get now, in order for you to understand them very well, you need to know the effect of estrogen on its on various organs. You need to know the effect of estrogen on various organs. For example, we're talking about the breast now. When estrogen acts on the breast tissue, it will cause growth. And whenever there is increase in growth, the risk for cancer is always there. Okay, so I believe if you want to produce a particular drug, you will not want to stimulate this receptor because the risk of cancer will be there. You understand? So when we proceed now, you will get to understand why tamoxifen will antagonize this particular breast receptor, because why we don't want excessive growth. You understand? Now come to the endometrium. What is the normal effect of estrogen on the endometrium? It causes what? Increase in growth. Again, it causes growth. And whenever there is growth, it will lead to what? It will lead to cancer. You understand? Whenever there's excessive growth that is uncontrolled, the cancer is not far-fetched. That's what I mean. Whenever your growth is not controlled, whenever growth is not checked, the risk of cancer is always there. Now, what is the normal effect of estrogen on the bones? Now, in the bones, estrogen reduces bone resorption. How does it do that? It inhibits osteoclast. It inhibits what? Osteoclast. Osteoclasts are bone destroying cells. So estrogen inhibits the activity of osteoclast. By so doing, it will ensure that the bone's density remains high, the bone remains strong. That's why in ladies that have approached menopause, you tend to see that they have brittle bones, because why? Estrogen is no longer there. So the effect of estrogen in the bone is a good effect that we want, but that in the breast, we don't really want them. You get? Now, what is the effect of estrogen on the liver now? The effect of estrogen on the liver is that it increases clotting factors. It increases the synthesis of clotting factor 2, 7, 9, and 10. So this simply means that estrogen is naturally thrombogenic. It can lead to clot formation in blood vessels. Then again, what is the effect of estrogen in the blood? What it does is that estrogen tends to reduce your LDL levels. It reduces LDL level. That's why when you compare a male and a female, provided the female is not yet up to menopause, the male is at more risk of having atherosclerosis. Why? Because the female high levels of estrogen protect her from tends to lower her LDL levels. Okay, so this is a good thing in the female. This estrogen plays a good role in ensuring that your LDL levels remain low. So these are the effects of estrogen in various organs. Again, I will come again with them. In the breast, it will cause increase in growth, and whenever there is increase in growth that is uncontrolled, for example, it could lead to what? Cancer. Same thing with the endometrium. Stimulate growth in the endometrium, and excessive growth, the risk of cancer is there. Then for bones, in the bones, estrogen causes it inhibits the activity of osteoclast, and by so doing, there will be reduction in bone resorption. So your bone will remain strong, and there will be increased density of the bone. Then for the liver, estrogen causes increase in synthesis of clotting factors. Okay, so there is risk of thrombosis in the blood vessels. Then for blood, estrogen reduces the levels of LDL, so by so doing, it guide against atherosclerosis. Now let's again come back to our discussion. We're discussing SERMs. It means that we are discussing drugs that we act on these organs. Now this SERM we're discussing now, some of them in certain organs they will stimulate, in certain organs they will inhibit. Okay, the first one we're discussing today is tamoxifen. Tamoxifen. So tamoxifen now, it can act as an antagonist. It can also act as a what? As an agonist. Now, tamoxifen will act as an antagonist in the breast tissue and also in the brain, but focus more on this breast tissue. It will antagonize the breast tissue. Now, if it inhibits the breast tissue, this is something we want, right? Because if you notice, when we talk about the breast, we said the breast there will be little, it will lead to what? There will be increased growth, and whenever there's increased growth, the risk of cancer is there. Okay, so for tamoxifen, we want it to antagonize the breast. We want it to inhibit the breast. Okay, we want it to inhibit the breast tissue, the estrogen receptor in the breast tissue. We want it to inhibit it. So that is a good thing for us. Then again, it will naturally inhibit the one in the brain also. So that is just it. Then for the bone, it will stimulate the bone, and when it stimulates the bone, it means that there will be increased bone density, because by stimulating the bone, it means that it is inhibiting osteoclast. So osteoclast cannot destroy the bone, so the bone density will increase. In like manner, this tamoxifen also stimulate the endometrium, meaning it acts as an agonist in the endometrium. So this one is bad for us. This one is bad for us. That's why, as part of the adverse effect of tamoxifen, it can cause what we call increased risk of endometrial CA. You can see it here. So for tamoxifen, there is increased risk of what? Endometrial CA. That is one big thing you should take note of there. Then for the liver again, it acts as an agonist in the liver, and when it stimulates the liver, it will lead to the synthesis of clotting factor 2, 7, 9, and 10. Okay, and when these ones are synthesized in increased number, the risk of clotting, the risk of thromboembolism increases. Okay, so that's why you are seeing thromboembolism here. Then for this, as part of the adverse effect, then for these hot flushes stems from the fact that you are antagonizing the vasodilatory effect, because estrogen has a vasodilatory effect on the brain, and if you antagonize that vasodilatory effect, what will come will be hot flushes. So the lady will continuously experience increased body temperature. Okay, as usually seen in postmenopausal women. So again, take note of the role of tamoxifen. It's an example of a SERM. It means that on certain tissues it acts as antagonist, on certain tissues it acts as what? Agonist. This particular agonist is partial agonist. So in the bone, it will stimulate the bone normally, stimulate the endometrium, stimulate the liver. So meaning the bone density will be in check. If you stimulate the endometrium, the risk of cancer is there. The risk of endometrial cancer is there. If you stimulate the liver, again, the risk of thromboembolism is there. So again, those are the adverse effects of tamoxifen, together with cataract alongside with liver toxicity. Now, there are some drug interactions of tamoxifen. But before we go to drug interaction, let me tell you about the main use of tamoxifen. What do we use it for? What is the major use of tamoxifen? Tamoxifen is the drug of choice. It is the drug of choice for estrogen receptor positive breast cancer. So it is the drug of choice we use for breast cancer patients that has estrogen receptor positive. You understand? So tamoxifen is the drug of choice for ERO positive breast cancer. So if you go to the world, you see it a lot. It's always the tamoxifen. Now, there is a drug interaction of tamoxifen that I want you to remember, and that is that tamoxifen is a prodrug. And this prodrug requires cytochrome 2d6 to be activated. So imagine your patient is also taking fluoxetine for depression. Fluoxetine is an antidepressant. So imagine your patient is depressed and is on fluoxetine. This fluoxetine also requires cytochrome 2d6. So imagine the patient is on. I know cancer patients, they usually go into depression. And if you are not giving these two drugs, tamoxifen and fluoxetine, to this your patient now, they will be competing for this what? For this 2 disease enzyme. And if tamoxifen is occupying this enzyme, what will happen is that, and if fluoxetine rather, if fluoxetine is occupying this enzyme, it means that tamoxifen might not be converted to the active form. And if it's not converted to the active form, it will lead to therapeutic failure. So that is one thing you should take note of. Tamoxifen has a drug-drug interaction with fluoxetine. Both of them uses cytochrome 2 disease. Okay, tamoxifen is a prodrug. It requires that enzyme to be converted to the active drug. So if you are giving your patient fluoxetine, you should take note of this. Okay. Now, what is the second drug? What is the second SERM we have? The second SERM we have is raloxifene. Raloxifene. Again, I said SERMs are drugs that act as agonists in certain organs and as antagonists in another organ. You get. And I mentioned that for we to understand them very well, we need to know the effect of estrogen on this organ, so that when we say it will act as estrogen here, you know what to expect. When I say it will antagonize it, again, you know what to expect. So for raloxifene acts as an antagonist in breast tissue. I mean, that is, it inhibits growth a bit. So this is good for us. Is that also? It's good for us. Again, in the brain, it does the same thing. And again, as an additional advantage, it also antagonizes the endometrium. So there is no thing like endometrial CA for a patient taking raloxifene. Endometrial CA is less. It's not there. There's no endometrial CA in raloxifene. But for tamoxifen, there is what? Endometrial CA. Then it acts as agonist again in the bone. So it's very, very important. This is the main clinical use of it, because it's used as a what? The main use of it is in postmenopausal osteoporosis. This is the main use of it. This is what we use it for most of the time. This is the clinical use of raloxifene, is as what? Postmenopausal osteoporosis condition. Okay. Now, again, stimulate the liver. If you are stimulating, and if you are acting as an agonist in the liver, it means that again there will be risk of what? Thrombosis, because you will increase clotting factor synthesis. So that's what you are seeing here. Again, hot flushes, because I'm blocking that brain, and thromboembolism, because I'm stimulating the liver, which will now lead to the production of clotting factor 2, 7, 9, and 10. Okay, so this is everything about the SERMs. So I will just do a quick recap. I said SERM are selective estrogen receptor modulators, or on certain estrogen tissues they act as agonists. On some they act as what? Antagonists. And I said for you to understand them, you need to know the normal function of what? Estrogen on those tissues, so that if I said this particular SERM is acting like estrogen on those tissues, meaning it's acting as an agonist, you know what to expect. If I say it's acting as an antagonist, you know what to expect. So those are the main things there. And I said there are two types of SERM. We have tamoxifen, and raloxifene. Okay, I said this one is used as a drug of choice in breast CA, that is ARO positive breast CA. Why this one is we use it as post menopausal osteoporosis, but it's not the drug of choice. So raloxifene is not the drug of choice for it. However, this is the clinical use as postmenopausal osteoporosis. The drug of choice for osteoporosis still remains what? Bisphosphonate. Those are the drug of choice for osteoporosis. Okay, so this is all for this video. In the next video, we will move on to the antagonist of estrogen receptor. Antagonist of estrogen receptor, like the full antagonist. This one we discussed, they are just in between. Okay, you remember in the first video we discussed just the estrogen agonists. Now we now discuss the ones that are partial. They act as agonists, sometimes they act as antagonists on other tissues. And in the next video we'll go into the full-time antagonist. Okay, so thank you very much.